looking for an explanation for infertility, a reason why we haven't had success over the last 6 to 12 months. Unfortunately, and for many patients, these tests all come back normal, and that really gives us to that unexplained infertility diagnosis. I certainly do get the frustrations. Yeah, I feel it. I feel it.
That was today's guest, Dr. Callum Potts from CCRM in Miami. And he was talking about that frustrating and often misunderstood infertility diagnosis called unexplained infertility. And in that little soundbite, Dr. Potts expressed empathy for those who receive this diagnosis. And that's not only because he's a compassionate provider of healthcare, but it's also because he and his wife experienced and overcame an unexplained diagnosis of their own. This is another one of our crowd favorite Fertility 101 episodes. And it looks like we really got the right expert to talk about unexplained infertility. I'm Dan Bulger with Progyny, and this is Infertility. In our conversations for this show over the years, this diagnosis is the one that seems to cause the most immediate frustration. The general sentiment we hear goes something like this: "What do you mean unexplained?" Or, "Oh, gee, thanks for the diagnosis of I don't know disease." But despite the frustration, it's a real diagnosis. And today, we're going to learn more about unexplained infertility. So let's get the expert on board to really break this thing down.
Yeah, so I think it's helpful to think about unexplained infertility by going back a few steps and just looking at what infertility is in the first place. So infertility as a diagnosis, which I'm sure many of your listeners will know already, but is for couples where the female partner is under the age of 35, 12 months of well-timed intercourse without successful conception. For couples over the age of 35, 6 months of trying to conceive without a successful conception. And when you get to that time point, that's really the point at which we would recommend seeking additional help, seeking an evaluation. There are other things, obviously, that should prompt an evaluation earlier if cycles are not regular, if there's sort of a known potential issue or barrier to pregnancy. But for couples that are otherwise healthy and just trying to conceive, those are really the time points that we think about. And at that point, it's worthwhile investigating all of the things that we have good evidence to investigate to find out if there is a specific barrier that's limiting or lowering the chances of pregnancy each month. And so we kind of think about, 4 big things that we need to conceive a pregnancy. One is sperm. And so an evaluation of infertility always involves the male partner, if one is present, looking at a semen analysis to look at, various parameters of sperm function, and making sure that those are within normal ranges. We're looking at a sperm meeting an egg. And so we look at various factors involved in how an egg is released. We can look at factors involved in ovarian reserve, which is basically the number of eggs that exist in ovaries. There are blood tests and ultrasounds that we can do to look at that ovarian reserve number. And there are also a range of hormonal tests that we can do to look at how an egg is being released, how the brain and the ovaries are talking to each other, and making sure that reproductive axis is intact. And so there are hormones from the brain, like follicle-stimulating hormone, or FSH, luteinizing hormone, or LH, thyroid-stimulating hormone, or TSH, prolactin. There are other hormones from the ovaries themselves, like estrogen and progesterone, that we can interrogate and look at to see if there's a specific hormonal reason why an egg may not be being released in an adequate fashion. Egg and sperm meet in the fallopian tube. So the third thing that we investigate are the fallopian tubes themselves. We're a little bit limited on how we do that. Realistically, the best way for us to investigate the fallopian tubes is with an imaging study, just to show that they are open or not. The specific functionality of the tube outside of being open or not, we're not really able to do. And then once egg and sperm meet, they become an embryo in that fallopian tube, and they travel down into the uterine cavity to implant to become a pregnancy. So the fourth and last thing that we can investigate is that uterine cavity, again, imaging studies or directly visualizing the uterine cavity with a hysteroscopy to look at what the inside of the uterus looks like, again, if there are any barriers to a successful pregnancy. And so these are all investigations that are looking for an explanation for infertility, a reason why we haven't had success over the last 6 to 12 months. Unfortunately, and for many patients, these tests all come back normal, and that really gives us to that unexplained infertility diagnosis.
Modern medicine is pretty amazing. It's truly remarkable when you think about some of the things we can accomplish today. But there are still limits, and these limits mean that there are things occurring in human reproduction that we simply can't adequately test for yet. And that means that unexplained infertility is actually a fairly common diagnosis.
It can be as many as 30% of couples that present for an infertility diagnosis that get that unexplained infertility diagnosis. Somewhere between 15 and 30% is typically the number that we would quote. So it's a pretty significant proportion of couples that present for infertility.
And so 15 to 30% come in for an evaluation and walk away with this strange mix of information. Everything looks fine, but we know something is wrong.
And that can be so frustrating, right? So, you've just gone through, maybe 12 months, maybe longer of trying to conceive with no answers, with no success. You go to a fertility specialist, you do all these tests, they take 1 or 2 months to do, and still at the end of all of that process, you get an answer that's basically, we don't know. Everything seems normal, but clearly you're not getting to the end point that you really want. So that is extremely frustrating. There are so many people that come into the clinic and get that answer and sort of say, well, I wish there was something that came up. I wish there was something specifically wrong, because at least that would give me something to ground these challenges in. But yeah, the unexplained infertility diagnosis can be really frustrating. On the other hand, just because it's unexplained doesn't mean that there's not good treatment options. So, we still have very, very successful treatment options, even though we don't have a clear reason to point to as to specific cause for infertility. I think the other thing is, unexplained infertility doesn't necessarily mean that there's no explanation, right? So we're pretty good at finding many of the causes. We can diagnose 70-80% of the causes of infertility, but we still have some ways to go in the development of the field to figure out the remaining causes. Just because it's an unexplained infertility diagnosis doesn't mean that there's not subtle changes that we're just not picking up on the tests. And, maybe there are 2 or 3 or 4 subtle differences in these parameters that we were talking about, that you need to get to a successful pregnancy. And, just that these changes don't quite meet our definitions, but, altogether may just contribute to a slightly lower chance of pregnancy on a month-to-month basis.
We're going to get into the treatment options very soon, but we thought it was important to include this part first. While the problem causing infertility could be something they just can't detect, it could also just be a simple bad break.
There's also sort of a statistical chance that potentially, 6 months or 12 months, we just haven't had the right egg and the right sperm meet. Couples with unexplained infertility, once you have that diagnosis, there's not a 0% chance of pregnancy. So, these couples have maybe 1%, 3%, 5% chance of pregnancy on a month-to-month basis, even with no intervention. So pregnancy is still possible. It's just less likely than we would expect based on that couple's age.
See, it's not all bad news. And even better news still, there are treatment options.
2 main treatment options that we have. Again, the first option is always, you can do nothing. You can kind of expectantly manage the process. There's an approximately 3% chance per month of achieving a pregnancy. So it's not high, but it's not nothing. The first, or the kind of least invasive treatment option that we could recommend would be some combination of oral ovulation induction medications. So these are medications like Clomid or letrozole, as well as an intrauterine insemination. And so the goal of that treatment option is try and take some medication to encourage the ovaries to make not just 1 egg each cycle, but maybe 2 or maybe 3 eggs. Just increase the likelihood that at least 1 egg will fertilize. And then with the intrauterine insemination, collect a semen specimen from the partner. We know that there are no abnormalities based on the previous testing. And then introduce a washed and purified specimen into the uterus, close to the fallopian tubes, close to where those eggs are going to be released when ovulation happens. With sort of regular intercourse, we only expect at most about 200 sperm to make their way into the fallopian tube. So if we can do this IUI procedure and bring millions of purified and activated sperm into the uterus to meet not one egg, but maybe 2 or 3 eggs, that combination of factors can help to increase the chance of pregnancy to somewhere between 8 and 12% each month. So it's not super high, but it certainly gives you a substantial increase over the maybe 3% chance of just trying naturally at that point. And then the other big treatment option that we have is IVF, or in vitro fertilization. That process is a little bit more involved, but what we do is provide medications to stimulate the ovaries to make not 1 or not 2 or 3, but as many eggs as we can that cycle, 10, 15, 20, 25 eggs if we possibly can. We retrieve those eggs from the body. Again, we collect the sperm specimen from the partner, fertilize the eggs with that sperm specimen, create embryos, and then either with genetic testing of those embryos or not, transfer an embryo back into the uterus at an appropriate time once that uterus is being prepared adequately. And that's the most complicated, it's the most expensive, it's certainly the most successful, or most likely to be successful treatment option. And so the varying sort of thoughts about which of those options is most recommended. I think that really becomes a very individualized discussion between the patient and their provider. But those are 2 really, really good treatment options that we have to help couples with unexplained infertility.
Okay, so there's 3 paths. 1, go back to trying and hope that this was just a mathematical anomaly, which is a valid path, but it does bring very low chances of success each month and might delay things considerably. Move forward with IUI, or move ahead with IVF. These are drastically different paths. As Dr. Potts said, it's a person-by-person decision, and there are more factors at play than just medical concerns given the cost of these treatments. But I asked Dr. Potts if there were any factors that could help people in choosing what path might be right for them. Outside of the big tests, are there any indicators that perhaps they could wait for IVF, or maybe they really are best off going right to IVF? And guess what? It comes down to age.
For couples where the female partner is under the age of 38, there's reasonable success with doing, what's called a course of ovulation induction and IUI cycles. And that can be 2 cycles, 3 cycles, maybe up to 6 cycles. Most providers will recommend about 3 cycles before moving on to another option if not having had the success that they wanted. And so that's reasonable. The cumulative pregnancy rates from those cycles is about 25 to 30%. So again, it's not 100%, but it's reasonably high. For couples that are 38 years or older, I think there's also a reasonable recommendation to go straight to IVF. The likelihood of having a live birth and kind of the accelerated chance of having a live birth, really becomes more important in the slightly older age groups, just to really get to the end point as quickly as we can. That being said, it's not wrong to choose either option, outside of those recommendations. So, for example, my wife and I have unexplained infertility, or had unexplained infertility. We had good financial resources, a good health insurance plan that covered much of the fertility treatment process, and our goals were to try and achieve pregnancy as quickly as possible. IVF is certainly the most likely treatment option to get to that point as quickly as possible. So, we chose IVF first. It made sense for us. Some people, really want to do sort of the maximal treatment as quickly as possible. And some people are a little bit more, trying things that are less intensive, less invasive. And so I think, both options are really reasonable. I don't think it's wrong to choose either of them. I think it's good that we have, at least a couple of options that are available to try.
So IVF would have the highest likelihood of leading to a baby quicker than the other options. And for those who are choosing to move to IVF, there's also an added factor at play too. There is a diagnostic element to IVF. I don't mean that people should do IVF to diagnose their problem. The point of IVF is not diagnostic, but an IVF cycle can actually answer a lot of these unexplained questions.
IVF is a great way for us to learn about some of those factors that we can't test for ahead of time. So, by removing the eggs from the body, or actually taking a step back, by stimulating the ovaries, we can get an idea of, maybe some factors about egg number or ovarian function that we just didn't know about before interrogating them a little bit more closely. When we retrieve the eggs from the body, we get a chance to look at them under the microscope, and there are some factors that we can see under a microscope that we just can't test for before doing that might give us a little bit of an explanation. There are different sized or different shaped eggs. There are different inclusion bodies, or just different factors about those eggs that we can kind of uncover as part of the IVF process. The next step is egg and sperm fertilization. So two big ways that we fertilize eggs in the IVF lab. One is just sort of placing egg and sperm in close proximity and allowing that fertilization process to happen by itself. And the second is ICSI, or intracytoplasmic sperm injection, where we pick up a sperm and inject it directly into an egg. And when we have couples with unexplained infertility, and we do this sort of conventional insemination approach, we do find maybe 3-4% of couples will have either substantially reduced or just no fertilization whatsoever. And that gives us a really good explanation as to why pregnancy hasn't been happening naturally, because there's some factor about that sperm, those eggs, that aren't working together to fertilize and create a healthy embryo. That can potentially be overcome by choosing the other fertilization method. But during that stimulation, retrieval, fertilization, and embryo development process, we can get a better sense of some of the factors that might be good explanations for the infertility that we just couldn't get insight on before.
So unexplained infertility isn't the end of the road. I think of it as bad branding. You never want to hear your doctor say they diagnosed you and also say it's unexplained at the same time. But semantics aside, an unexplained infertility diagnosis can be seen as an opportunity.
It's a tough one. It's a really tough one. It's one of those diagnoses that I think most people are unhappy about. Some people, a lot of the time, I'll sort of have couples that sit across me and say, I wish there was something about my ovaries or the sperm or the tubes or the uterus that we could just explain why this hasn't worked so far. But it really is it puts couples in a good position when we get to the treatment options, right? Because by default or kind of by definition, ovarian function is normal. We expect good numbers of eggs. Sperm function is normal, so we expect good numbers of sperm for any of these techniques. The uterine cavity is normal, so we don't need to undergo any kind of surgical treatments before we get to the point of doing some sort of infertility treatment. So I think there are a lot of positives that can come from having this as a diagnosis. It certainly doesn't feel like that when you get it, but there are good treatment options that lead to a good likelihood of success. And I think especially this day and age with the success of treatments like IVF, I'm optimistic when I have a couple that sits across me with this diagnosis.
If you're listening to this episode because you were diagnosed with unexplained infertility, we hope this is helpful. We know it's frustrating, and we know it might leave you feeling like all of those tests just led to more questions. But the big picture is one of optimism for those with this diagnosis. Learning that everything appears to be functioning means that all of your options are still open. I want to thank Dr. Callum Potts for joining us today. And of course, I want to thank you for listening. If you want to connect with us, you can do so on Instagram at This Is Infertility Podcast. And you can also follow Progyny at Progyny Inc. on Instagram as well. This Is Infertility is brought to you by Progyny. Please remember, this podcast is not intended to substitute for the personalized expert advice of your physician. I'm Dan Bulger, and this is Infertility.